Hi, everyone, and welcome to Ask a Death Doula. We are now doing the Good Death podcast series, and it has been phenomenal. Don't forget, pre-order your Good Death book, and you get a ticket to the live masterclass on March 22nd. It's going to be an amazing event. Don't miss out. The event for the ticket is free with purchase of your book. So this is the Good Death seminar series, and what we have done is we have curated so much great content that we are now going to be sharing with you parts of those seminar series. If you weren't able to attend, here it is for you. It's all here and it's all amazing. So in this episode, you are going to learn about hospice care, the hospice gap, and what you need to know to fill it. So please sit back, relax, enjoy the podcast, and we'll see you at the end. The Good Death Seminar Series, this is your second one, and this is hosted by Doula Givers Institute, so welcome. I want to start out by sharing that we will all be called to show up for someone at the end of life, and knowing how to do that changes everything. And this is really important and why we're here tonight, because even if you are not the one that you find yourself caring, doing the hands-on care for somebody, what is going to happen is that you'll know somebody, there'll be a family member. You want to be educated and comfortable and empowered within this space to know what to do. And here's the reality that many of us will be called to actually be the ones caring for people in conjunction with other family members. And knowing how to do that is critically important, and it changes everything. It also is a real honor to be caring for people at the end of life. So I want to start out by just being real about the fact that in this life's journey, all of us will be called one day, maybe several times, to show up for someone. And knowing how to do that, having the skills, changes absolutely everything. This is seminar number 2. This is the Good Death Seminar Series. And tonight we're going to talk about what is hospice care, how does it work, what is the hospice gap, and how you can fill it. And again, knowing the truth about what's happening right now and knowing how we can fill the gaps within hospice care changes everything for what you're going to experience. And if I may, I'd like to introduce myself. My name is Suzanne O'Brien. I am a registered nurse by trade. I'm a former hospice and oncology nurse. I have over 20 years of experience. I've worked at the bedside of I've been honored and privileged to work at the bedside of over 1,000 end-of-life patients. I've trained over 350,000 people on how to care for those they love at the end of life. And I've been honored to work with people all over the world in different cultures and different religions. And this has given me an incredible amount of knowledge that I want to share with you within this space. When most times people don't know the first thing about end of life, it allows me to use all of that experience to be able to create trainings and to be able to share with you about end of life in its highest level, its highest form, so that you can know how to care for somebody that you love at the end of life. I am also a founding member of the NHPCO's End of Life Doula Council, that's in the United States, and I'm a founding member and former vice president of NEDA, which is the National End of Life Doula Alliance. And I wanted to tell you about my why. So yesterday as I'm working really hard on these seminar series, creating them. And I have to tell you that teaching is my love. I would do it for free. And I guess I do, because here we are, right? But that's okay. I love to share my knowledge with you because I know what it can do for families. And here's what I say to myself. I know that sometimes things can seem like we have so much that's going wrong and there's so much room for education in this space. But I want to tell you this, that when I'm working hard on these and I'm doing the education, I tell myself that if it helps one person, if one of you tonight who shows up and it changes the trajectory for you and your family to be that of so much more positive, it's worth it. So I hope it helps so many more, and I believe that it will, but I also want you to know that I know that I'm making a difference, even if it helps just one person. And so it's really my soul food. And I really want you to know that finding your soul food is incredibly important too, because we're all here for a reason. And I know it can feel overwhelming and like what we do doesn't matter, or the small things that we do, they do matter. And so I just wanted to share with you my why, so you understand, well, why is this woman putting on this whole seminar series with a workbook and doing it? And why is she doing it for free? Well, because it can make that big of a difference. And again, I help one person, it's a win. So in this seminar tonight, you are going to be able to, what we're going to cover is we are going to talk about the original purpose and origin of hospice care. And I always will teach from a place of, if I'm trying to teach you something, and again, there's never any judgment with anything that we do, and I want to make that clear. But I also want to make clear that we make very clear observations. And I always look to, where did this start? Where did the origin of things start? How did we get to the place we are now? And what do we need to put in place to change it moving into the future so it can be better? So I'm going to share with you the origin and the purpose of hospice care. And it's really fascinating and interesting and inspiring. I'm also going to share with you the impact of Medicare's reimbursement structure on hospice services. I want you to learn what families can do to fill the gaps in hospice care. And I'm going to teach you about the essential questions to ask when choosing a hospice provider. These are very empowering things that you are going to learn. So part number one, under the understanding hospice care, what hospice does, and I often will say what they don't do. And it's interesting when I do these, and I have to tell you that doing the research and building programs really does help me get really clear sometimes on what I think can be better ways to move forward. And one of them I'm going to share with you tonight that came very clear from this. So understanding what hospice care is, what they do, and what they do not do. So the definition, what is hospice care? Hospice care is a specialized form of healthcare focused on comfort and support to individuals in the final stages of a terminal diagnosis. And so it's a focus on symptom management. It prioritizes quality of life. So that phrase, quality of life, is extremely important for many reasons. But it also manages pain and physical symptoms while also offering emotional support, spiritual support to both the patients and the families. The care is delivered by a team. Now, I put in the word consulting. So this is the definition. It's delivered by a team of professionals across settings, including homes. Mostly it's done in homes, but it can be in hospitals and other dedicated hospice houses or centers. I put in the word consulting there because I think one of the big things, and we'll journey through this tonight, is the real misunderstanding of what hospice does and does not do. And I think that if it was clear to families that they are a beautiful, collaborative, professional team of consultants. Why is that consulting word hard? Super important. Because of the small amount of time that they're actually with the patient and family, that the family is doing most of the care. Most people do not understand what hospice does, what they don't do, until it's too late where they're in it, and then they don't have the setup for it. So what I want to share with you is the reality of being clear about what hospice care offers, and they're wonderful in its model. But again, what is the gap there that is causing, unfortunately, most end of lives to not go as well as they could go? The admission for hospice criteria means that a doctor has determined that someone has 6 months or less to live of a life-limiting disease process if it follows its natural path. Now, can it go more than 6 months? It actually can. So there are times, doesn't happen often, but there are times that people, well, you see President Carter, he's a great example. Getting readmitted, not dying. And there's interesting reasons why that is so. That's a personal thing that's going on. But for the majority of being admitted to hospice services, a doctor has to deem that you have 6 months or less to live of a life-limiting disease process. Well, that sounds all well and good, right? 6 months. Do you know what the average amount of time that people are on hospice services right now is? About 14 days. So there's a couple of reasons for that, but that's leading to the challenge before us. So I want to share a story with you about my mom. So my mom worked in medical her whole life, pretty much her whole adult life. And at the end, she was a hospital administrator. So she was tapped in with all of the, things that go on in the hospital and everything of that nature. And when I was hospice nursing, I would be really sad and frustrated and confused at the things that I saw. And my father is a former doctor. So I would talk to my family about the frustrations, about me being there for 1 hour once a week, and that this family, it's not going well and they need so much more. And my mother said to me, "What do you mean?" She said, "You don't go every day to that family?" And I said, "No." I said, "I go once a week for 1 hour." So now people within the medical profession don't fully understand what hospice does or what they don't do. So there's a lot of, unfortunately, lack of clear understanding. And that clear understanding is super important for us to get these patients and families what they need, including what doctors know about hospice and how they should be referring patients to hospice probably way sooner than some of them are. And there's a few reasons for that. So hospice, how it started. So this is a picture that I found online. It's not an actual hospice house, although it should be because it's super cute. I was trying to just find a home that had some warmth and character to it. But the word hospice actually means host house. And hospice started as a concept of a house that would take care of people at the end of life, holistically, and in all of its beauty, how it was created. And isn't that a beautiful thing? And I think it is. And I hope and I pray, and I know that miracles, I'm realistic, and I know that miracles do exist. I really hope that we are able to bring back hospice houses in a big amount, because they're really needed, because a lot of families can't do the care. And also some patients don't have families to do the care, but most of the hospice care in the United States is done in the actual home. But this is how it started. Host house means hospice house. Now, let's talk about this woman. So how it all began, Dame Cicely Saunders. And again, some of this information was a little bit new to me. I knew Cicely Saunders. I knew she was a founder of hospice in England. But what I didn't know is that she was a nurse, she was a social worker, and she was a doctor. Well, I mean, hands down to you. So this woman pioneered a movement of hospice, and it started in England. She started Christopher's Hospice in London in 1967, which became the model for hospice care worldwide. She does much education, much speaking about. She introduced the concept of palliative care, of managing symptoms, of comfort care, of trying to teach doctors and tell doctors and share with doctors, you can't fix this. You're not supposed to fix this. Stop trying to cure that person at a certain point. That's no longer proper or humane at some point. That managing their symptoms is, that end of life is a natural process, and that it's not just a physical process, that it's an emotional, spiritual, and mental process as well. So this one woman started that. She introduced the concept, focusing on, again, pain management, emotional, spiritual support for not only patients, but for their families as well. She does much education and writing, and I really love how she pitched this as really trying to, and I always want to use the most loving words that I possibly can, really trying to share with doctors that they need to stop trying to treat somebody when it's an end of life situation, and it should be focused on holistic comfort. So that was really the first person who brought this in. So what happened next? That was in 1967. And when I think about that, that's like a stone's throw away. Now, in the United States, the hospice movement started gaining momentum in the 1970s. The first hospice in the United States is reported to be Connecticut Hospice, and that was established in 1974. Now, here's where we want to pay close attention. The movement was further advanced by the Medicare. I'm sorry, people keep coming in. Erica, if you are behind there, if there's a way that you can admit people, that would be fantastic. Okay, the movement was further advanced by the Medicare hospice benefit. This was introduced in 1982, which provided funding for hospice care and helped expand its availability across the country. But with that came issues. And so when we want to say, how did a concept that was so beautiful in its origin, how did we get to a place that it's not working well? And there is the answer here. And so the answer really is, and I guess, I always want to say, okay, so on the positive side, this expansion of the Medicare benefit allowed for a wider range of hospice care to reach people, but the hospice care changed and some other things changed as well. So let's dive into that. Now, hospice began to emerge as a for-profit entities in the United States, primarily in the 1980s and 1990s. So first, this was really a nonprofit entity. A lot of the hospices were funded by donations and grants and things of that nature. And then when the benefit came in, it started to be shifted to a for-profit entity. And if we know about for-profit entities, again, we're not pointing fingers or being judgmental. We're being very clear on where we went down a wrong path, perhaps. And I'm going to say absolutely. When things are a for-profit entity, the bottom line is what is being looked at. The bottom line is always going to be the focal point. Well, the focal point should be the patient. The focal point should be the family, period, at end of life. I mean, in all healthcare. So now in the United States in 1980s and 1990s, we have the advancements, and we're starting to see the for-profit entities start to come into play. Now, this is following the establishment, again, of that Medicare hospice benefit in 1982. The guaranteed reimbursement from Medicare made hospice care an attractive business opportunity, leading to a significant increase in the number of for-profit hospices and providers. So that is what we're seeing, and that is what happened. So that is in the 80s, that is in the 90s. And what happens then is there's challenges to the hospice care. So let's dial this back into the actual care of the patient and the family. Over time, with how this has materialized into a for-profit, the rise for-profit hospices introduced concerns about, again, the quality and the access to care that people were getting. The quality of care, the cost-cutting measures can affect staffing. They affect the level of care provided. The average visit deemed by Medicare says that a hospice worker is only in the home on average for 30 minutes a day. On average for 30 minutes a day. That equates to 2%, which is 98% of the care is done by families. Remember, I had put in that word consulting, and I think that's really important for clarity, if we can, establishing it moving forward, not pointing fingers, just the reality of what is in front of us and how we need to fill that. So the profits over patients. So let me just, pose this question. Did this for-profit model now focus on the profits rather than the patients? And I think that we all know what happens. Now, I want to say that the hospice workers that I have worked with in my journey have been just the most amazing people in the world. They show up, they are angels, they are doing work, they are killing themselves to try and make a difference. So the stress on them, the stress on the patient, the stress on the family, the whole thing is really not working. And I think we need to get very clear and real about that so we can make some positive changes. So let's do a group discussion. And I want you to put this in the chat. So we're going to jump into the chat in a minute. And I just want you to take a minute and think, how do you envision the ideal hospice care for a loved one for yourself? And if you want to put, what would be one or two words that would be the main things that you really would want from a hospice worker, from hospice care, for you caring for your loved one? What do you need and what do you think is the main thing that's missing? So let's kind of jump in the chat and see what we get here. I'll start reading some of them. I know that I have my take on it. I think it could probably be a few things, but let's see what we've got here. Love it. Okay. Frequent visits, time, education. Yeah. Care, yes. Clarity, how to care for somebody, right? Comfortable, yes. Compassion, support, clarity, time, more attention, yes. Consistency, support, guidance, knowledge, yes. Support, okay, love it. Beautiful, guys. The same presence, I love that. Consistency, empathy, time and comfort, patient first, patient should be first, period. Love, phone support 24/7. I love that. We'll get back to that one. Kindness, personalized listening, compassion, more time from hospice. Yeah. No one alone. Love that, Nan. Thank you for that. A workload where they can visit each day. Wouldn't that be great? I love that. Trained help. Yeah, more time. Beautiful. Education, training for family. Yeah. Okay. You guys are right on top of it. And it's really true. So the common things that we're seeing right there, time, education, support, all of that really dials down into time. Because if you go back to the concept of what's happening with hospice today, and it's a beautiful model of care, how it was born. But because of the reimbursement structure, it's struggled now and there's major gaps. So if I am the hospice nurse and I am supposed to teach the family how to do the actual care, can I ask you something? How can I possibly do that with 1 hour once a week with this family? Do you think I can teach them how to care for somebody who's dying in an hour? No, I can't. And that was what I was sharing with my family, that I was frustrated and I didn't understand how this wasn't going well. So knowing that we need more time, we need more education. And of course, if it's not going to come within the system, and again, I think that if we're ever going to bring up obstacles, I think we need to bring up solutions to them. So knowing that we are struggling with the current reimbursement structure, which we are right now today, what do we have to do to help families and patients have a positive end of life and get the support that they need? So let's talk about the hospice gap. These are the things, these are the real chunks of missing pieces in hospice care that are creating these end of lives that are not going well. And it's really due to a fragmented Medicare, a fragmented system of care due to the Medicare reimbursement structure. So let's dive into that. While the Medicare hospice benefit increased access, it also paved the way for potential profit-driven motives. Many hospices now operate as for-profit entities, raising concerns about the quality and consistency of care. I get called every day. I have people tell me how it didn't go well for them. It's not going well, and there's no finger pointing. I don't think that helps anything, but we've got to be clear about the gaps and clear about what we can do to help change that. I call this a trifecta. So I feel like there is as my mother would say, it's a perfect storm. So it's a perfect storm of what we have right now that's creating this really unfortunate end of life experience for many people. This is what I call, again, the huge lack in good deaths is for these three main reasons. Number one, death is the number one fear in the world at this moment. It's the number one fear. And I just want to sit with you for a minute and say, how did something that is 100% guaranteed for all of us, how is something that has been going on for thousands of years, how did that become the number one fear? And do you know what happens when we're fearful of things? We don't learn about them. We actually sometimes become paralyzed. So this fear is driving many different things, like telling doctors to fix end of life, to do something to try and extend the life. And I'll tell you this, that as medical professionals, we know how to extend life. We know how to keep people, their heart beating and keep people breathing. But the quality of life that we talked about in hospice, there's a big difference between keeping somebody alive and living. And if we don't think ahead of time what quality of life is for me, and if I'm fearful because out of the blue, because I haven't been living with the awareness it would happen, this doctor tells me that my mother's at the end of life and we need to intubate her or she'll die. What do you think fear is going to do? It's going to tell me, intubate her, she's going to die. That's all I heard. So we have to be really mindful of this fear around death. And I just want to plant a seed for you right now. is it something that really needs to be feared? I just want to plant that, because I've been with so many people at the end of life, and I'm going to tell you that it's completely changed my life. The beautiful end of lives that I've been privileged to be a part of, what patients have said. But when we're not prepared and it's not going well, yes, it can be a very traumatic experience. The second part of the trifecta is the late time that people come on hospice services. The average in the United States is 14 days. Do you remember how often I visit as a hospice nurse? If everything was going normally, like nothing outside of the norm, once a week for 1 hour. Do you think I can teach this family and help them to have that good end of life? Looks like I was there for about 2 hours. It's just not working. And the fear in front of them is causing a big issue as well. The short amount of time that a hospice worker is in the home due to the Medicare reimbursement, and Medicare stated this in a finding, that the average is 30 minutes a day, whether it's a nurse or a social worker or an aide, it's an average of 30 minutes a day. This is not a working model, and it needs changing, and it needs supplementation. I want to talk to you about a story about Mr. Penn. And this probably is the fire in my belly, these stories and these patients, of why I will tirelessly do everything I can to provide education, clarity around this space. This gentleman was taking care of his dying wife. And he said that hospice said to him that when she is dying, call us and we'll be there for you. And he said that he called, she was dying, and he called, and he called, and he called, and they never came. And she died, and they never came. Guys, this can't be this way. It should never be this way. And he can't go back and do this again. And I also want to tell you this, that no matter what age you are, end of life cannot and should not ever be done by one person. There should be more support there. So when I hear this man share his story, and he's so baffled how they never came. They said they would come. So we have to move forward to change this. And I know that we're doing just that. So in his honor and all of the honor of people before him and after him, we are here to make that change, and we're doing it together. Let's do a bit of a reflection exercise. I want you to consider your expectations for hospice care, which we've talked about. And then when you all shared what was important to you for care for your loved one, how do these expectations align with the current state of services that are available in the United States right now? And unfortunately, a lot of countries. So we know we want that time. Is that in alignment with what's available? So let's jump in the chat a little bit and just talk about that, because getting clarity around this is super important. Yeah, nonprofit hospices are the best. Yeah, beautiful. Not sending the family home. My daddy died alone, and it has been traumatizing and 100% preventable. I'm so sorry. Maria, I'm so sorry about that. Yep. Great. Non-discriminatory. Yeah, absolutely. Chris says respect and patience. Yeah, Alex says it's impossible in 1 hour. It's impossible in 1 hour. And so how can that be the only thing we're offering? It's not working. It's not working. And when I went to my hospice CEO and said, we have to do more, do you know what he said to me? That's all we can do. This is back in the day. This was like before doula givers and everything. I said, it's not going well for most of the families. We have to do more. And you know, he said to me, that's all we can do. We can't do more. The minute that we put a dollar amount and the minute that we put a time limit on end of life, we're doing something wrong. And you can say that to whoever is in the care here. The minute that we've said, because end of life does not work that way. When somebody is dying and I have a 60-minute visit where I know that that person's going to die and that family's not okay, and I have to walk out of that home, I have to tell you as a practitioner, that is one of the worst feelings you could ever feel. And yet, you know, within the system, unfortunately, that's what it is. So let's keep going with that dialogue for a minute. I think that these things that you are saying are right on spot. Trudy says, all of my patient families had my personal number. They knew I was there no matter what. They never abused calling me. I love that, Trudy. And I will say that I worked over hours for my hospice families as well, not being paid, by the way, but we only have one opportunity. Plus, you know, if I'm up to 2 o'clock in the morning doing note taking because I wouldn't do it in the home I was working, I mean, that has a shelf life on it. Believe me, I did try within the system to be all things to all families, and it's just impossible. Ruth said I couldn't turn my mother to. Ruth says I could not turn my mother to clean her poop off. She was uncomfortable and felt disgusting. Okay, so let's all breathe into this for a minute, because you have to understand that end of life cannot be done by just one person. I don't care how strong you are. I don't care how young you are. Absolutely not. And also the real rule of thumb too is, if this is the final time with a loved one, we want to allow that spouse or family member to have as much quality time with the person, not being exhausted, not being doing all the tasking. So just keep in mind that we just don't want one person. Okay, Sean Thies says, one of the frustrating things is different nurses showing up and they do not communicate very well between each other. Hence, patients get different info from different staff and it gets confusing. Yeah, that's a great observation. And I've also heard that because you've got all these people kind of coming in and coming out, I've heard from patients and families, they don't even know who's the nurse. They don't know who's who. So you're taking a stressful situation and you're creating more chaos within it. And this family needs everything other than chaos. They need to have a calming environment, clarity, support. I love that. Nancy says, education such as death cafes can educate the public. Yes, Nancy, I agree. Sarah says, made me feel like people in and out quick of hospice and it feels rushed. Yeah, of course it does. You know, in my last time in my hospice, they said their policy was that you had to take your laptop in and do the documentation on the hour visit. So my 1 hour visit once a week with my patients, they said you have to document on it. And do you know what it's like when someone's face is in the computer? They're not present with you. I said, I won't do it. And they said, okay, you have to midnight to get your documentation in. And so every night I was just up doing it at home because I would never do that. Yeah. Okay, great. Chris says the hospice that is helping me get my hours has BSP, bedside presence, for end of life, but the execs get mad if they are put on BSP too soon. The execs get mad. Okay. Yeah. So I think that we all want education within this space. We would love time within this space for our loved ones. And even for you, because I want you to know that you as the family caregiver, it's really important for you to do the care. So it's really important for you to love and care for your loved one as they're leaving this world, just as they did when you came in. But most of us don't know how to do that. And so what I want to share with you is even just having somebody who can answer questions, hold the space for you, allowing you to know, yes, that you're doing it right, or this is what you should be checking your mom, or we should be putting your support system scheduler together so you always have another person with you. Like having things in place before we ever get there is really important. So I know that we want family caregivers to feel empowered and safe to be able to do the care. They usually just don't know how. And when you're scared, sometimes you don't even remember what you had for breakfast. And so when you're looking at your mom in her last final phases of life, do you remember even maybe what the hospice nurse said on her brief visit? I don't think so. By the way, they say it takes 7 to 11 times to hear something to really learn it. I don't know if it takes that many, but I know it takes more than once, especially in this space. Teresa says rural families that are remote find even less availability and time from hospice care. That's tragic. That's why we need to have community caregivers in every community so that they know how, they have the skills, which by the way, used to be the way it was. There was a woman in the community, in the village, she knew end of life and she would go to the houses, but we need to start bringing that back to rural areas and that all around the world as well. That's okay. Yeah, it happens in hospitals too. Hospice doesn't show up. Yeah, big sad gap. Okay, so we know, and again, we're not trying to get judgmental and go down a negative path. What we're trying to do is say, okay, what do we need to do to fill this gap? What do we need to do to support patients and families so they can have what they need when the time comes, that they can fill in the gaps with hospice care? Danny says, doula givers are the support that the dying person needs and the family needs. Absolutely. Yeah. Anna says, I had a delivery service bring me a medical device at 10 p.m. at night with no instructions on how to use it when my father was bleeding from his mouth. I am so sorry. Okay, we are going to change this, guys. We are absolutely going to change this. Let's go on. I want to thank you for that, because if we can get really real on what our hopes and expectations are for our family, what the gaps are and how we can fill it, we can have those good end of lives. So let's continue on and talk about these gaps that we're going to fill. Despite its origin, which we know was done by an incredible woman who is a nurse, who is a social worker and a doctor, kind of blows my mind, everyone. But I mean, good for her. I want to do a little more work on that. But despite its creation in the ideals that it had, hospice care often now falls short in practice, with many, 98% of the hands-on end-of-life care being done by family members when they usually don't know the first thing about how to do that care. I often think that's cruel. Families usually don't know the first thing about how to do end-of-life care, yet as a hospice nurse, that is exactly what we expect them to do. And again, that's the way the model is set up right now, and we all know that's not a good working model. So what about this? Let's just take a minute. And what about thinking if they rebranded with clarity what hospice services really are right now? And you do get a social worker, you do get a nurse, you do get a home health aide, you do get spiritual care if that's what you want. What if they rebranded it with clarity to say that it's a disciplinary group of consultants? Because isn't that really sort of what it is? If I'm coming in, looking at your mom as a hospice nurse, assessing her, and then telling you how you're going to do the care, how you're going to do it, that's a consultant role. So if I know that hospice care is a consulting, that, wow, they're not going to be here all the time, I know that what do I need to do to get educated and grounded so that I can show up for my mom, show up for my dad in the best way possible when I know that it's going to fall on me. So if they're coming in, that's great. I know they're coming in. I also know they're leaving. So what do I have to do to fill that? So what if we thought of them, and I would love, and I probably will, talk to hospice. I mean, obviously, you know, we love people who do hospice. Workers are just incredible. The model's not working. And what if they had clarity around their model? Look, this is what it is. It's a Medicare reimbursement, but it's almost like the people and the families are finding out what hospice does not do when they're in it. And that is not the time, because that is just crushing. So think of them as coming in and consulting, and they do a beautiful job at that, but it is really a consulting role for the most part. So what are we going to do to fill the gap? Families can take several steps to bridge this gap. Number one, educate yourself. Gain knowledge about how to care for somebody at the end of life. We give this every month for free. This is the level 1 end-of-life family caregiver training. I promise you this, in 90 minutes, and it's live, it's not recorded. In 90 minutes of your time, you will learn how to care for your loved one from the beginning of when they get a terminal diagnosis all the way through to setting a sacred space. I fill it with inspiring stories, real bedside stories of those at the end of life, interventions to use for comfort. And I have given this to people all over the world with great success. If you are fearful of end of life, this could change that. If you are holding on to grief, this could change that. This is the feedback I'm getting. And if you want to feel inspired about life and empowered, this training that is free, by the way, will do that. There's one tomorrow night. We'll be able to share that link with you as well. They're every month. Number 2 is ask the right questions. Ensure that you're informed about the care options and facilities available. I think one of the things that we forget is, yes, it's insurance reimbursed, but you're the consumer. You're the consumer. And so you're allowed to ask questions. What I think is happening today is you don't know what questions to even ask, that you're, really depending on the guidance from the organizations, and there's just no time to really do a lot of that education. And number 3, and I really want to land this for you, is plan ahead for end-of-life care. Think about what you would want or not want. And I know that I highlighted that quality of life statement, and I want you to know that quality of life is your benchmark. And it's something that is going to be different for each and every one of us, meaning this, that when a time comes in our journey where my quality of life is not there, I'm not able to walk, I'm not able to recognize my loved ones, I can't do anything for myself, I have lots of pain all over. My quality of life is not where I want it to be. And I do not want, and I'm speaking from myself, Suzanne, not just as Suzanne, and my quality of life would be compromised to the point that I don't want my family doing any extended measures to keep me going because my quality of life is not there. In fact, I'm really suffering every day. And we see that happening when people don't choose for themselves. Now, on the opposite side of that coin, when I think about quality of life for me, and I think about all of the choices that I do have when I get to that space where symptom management, comfort measures will be instituted. What is important to me? Well, first of all, anyone who's real close to me, well, my family usually, knows that I run cold. So some people run warm in their temperature, I run cold. And so, yes, I would like warm blankets. And yes, I want to make sure that I'm warm. And yes, I love my animals with me. And yes, I would love music. And these things are really important too. And of course, I don't want to be in a lot of pain. Like, why? Why would I, pain management is the most missed area of, and here's the thing that really is heartbreaking. Families are doing 98% of the care. They're the ones that are doing the pain management. They're usually absolutely unaware of how to do that to the level that they're so afraid of doing it wrong that they don't give the medicines. So, I mean, that is tragic in and of itself. And so what we're talking with pain management, we're not talking about being knocked out and, flying on a cloud. We're talking about bringing down pain that could be an 8 or a 7 that's relentless to a 3. I know it's there, but I can still have a conversation with my loved ones. So again, understanding pain management and how it works for our families, probably one of the most important things to teach them, but also one of the most missed areas in care. So what does that equate to? That equates to patients dying in pain or suffering because the families are not taught properly. They don't know. So we need to change that. So planning ahead for yourself, for your loved ones, asking them where they'd want to be, what's important to them. And we have at Doula Givers, we have what's called the 9-choice advanced directive document. That again is a free document for you that we've curated 9 of the top questions that need to be answered to really have that positive end of life. And it's something that you can access and just look at, and then you can have discussions with your family. So the end of life discussion, uncomfortable? Yeah. But I'll tell you this, a little bit of uncomfortable now will save your families and you from so much more suffering later on. I promise you that. And there's also something that the reality of end of life, the reality that this journey will one day change, how it changes your life. Because when I start thinking, oh, okay, this is definitely going to change one day, I look at each and every day very differently. I appreciate my level of gratitude and appreciation of, and I want to say simple things, but I think the small things are sometimes the most beautiful. Going for a walk with my dog, saying hi to people, looking at nature, being able to go for a walk. Like, when you're aware that one day, I mean, you just appreciate everything that you have. And you appreciate your relationships within your family because, one day you're not going to be able to call your mom on the phone and have her answer. So there's a real level of appreciation that comes with the awareness that one day this journey will change. But also for you individually, this is one of the greatest gifts you can give your family is making these choices, because if you don't, it falls on them, and they usually don't agree and they don't know what you want. This is one of the most important things that you can do. Part number 3. These are the questions to ask when choosing a hospice. So I'm going to give you a couple of questions that I want you to know about when you are choosing, and I want you to remember that you are the consumer. So you're the consumer, and many times it doesn't feel like that. It doesn't feel like that. It feels like you're going to get what you're going to get, but you actually have choices. So when you're evaluating hospice options, I want you to consider asking the following. Number 1, what services are included in your hospice care? Oh, what do you mean? What services are included? Well, a nurse will come, and we're gonna kind of talk about how often on the next question. But just ask them, pose that question to them. Number 2, who will be part of the care team? Let's get that really clear. And how often will the visits occur? Because if I was taking care of my mom, not as doula givers, not as a nurse, and I asked that question to a hospice, and they told me that they were going to come once a week for an hour, well, I would be shocked. I would panic, but I would go into mode, and hopefully I would be finding this out before, as we're doing now. So I have backups, my sister, brothers, hire some help, whatever it is to fill in that space that I know is going to be needed. So ask them how often they're going to visit. Number 3, how is pain and symptom management handled? As a hospice nurse, when I was visiting once a week, there were so many times that I'd come into that patient home on that second week visit, and sometimes they'd be on longer. And for days, that person would be in struggling pain and things would be happening that the family didn't let anyone know. And you know why the family didn't let anyone know? Because they didn't know what was going on, and they were so upset. So I walk in, and now the pain regimen that was working is now not working, but they didn't know enough to call. So we have to get really clear again on asking questions and getting education that changes everything. What support is available for my family caregivers? Social workers. The nurse can sit with a family, but again, there's a short amount of time that we're there. Number 5, how does your hospice handle emergencies or urgent needs? So again, if people were not having anything out of the ordinary, I was there once a week for an hour. If there was something actively going on, the family called us, we could schedule a visit. Now, I don't even want to begin to tell you what it looks like when you have all these patients to try and schedule in a visit that is unexpected. It's pretty difficult, but it can be done. But number 6, ask this question. Do you have on-call nurses? Because I have heard that there are hospices that are doing away with the on-call nurse overnight because of the cost. So, you know, I can't verify this. I know that it's sketchy, but I also know this, and our on-call nurses were just amazing. We have one nurse that was on call at our hospice overnight. If she or he had 3 calls or 4 calls that came in, and by the way, the hospice nurse pronounces people who've died. So one of their roles is to go to the home and do the time of death pronouncement. So if she or he had 4 different people calling with different issues, Mr. Miller's having a lot of pain, or somebody, you know, something else is happening, or somebody, you know, is bleeding, or something happened and somebody died, she's pronouncing, she can or he can only get to those families in the time that they can get to those families. So somebody may be waiting hours, and that does happen. So you want to make sure that you're asking those questions. Those are really important. And please remember that you're the consumer. You're not asking these questions because you're pointing fingers at them or accusing them. You're asking them so you can be informed, so that you can make sure that you're making the right choice for your family, and that you can fill the gaps that are so very much needed. So in conclusion, understanding the intricacies of hospice care and recognizing the potential gaps can empower you to be informed and make informed decisions for you and your loved ones. By asking the right questions and seeking the necessary support, you can help ensure a compassionate and dignified end-of-life experience for your loved one. We only have one opportunity to have the end of life go well. We cannot go back and do it again. We have to do everything that we can. And please remember that bringing back the sacredness of death brings back the sacredness of life. And together, this is how we change the world. So when you show up to learn this, it empowers you, but hopefully it also opens your eyes to the fragility of this beautiful experience we've been given. And every single day is an opportunity to express as what you want to express, not to miss it. I want to thank you so much and let you know that you are the change. So this is where it starts. It starts with us showing up and getting the information. And please, death is not a medical experience. It's a human one. And just like Cicely Saunders said, it's a holistic one. And here's the reality. It can go well, really, really well with the right education, kindness, and support. Thank you so much, everyone, for being part of this episode. It is the Good Death podcast series. And again, you can grab your Good Death book right now and get a free ticket to the live virtual masterclass where I'm going to be sharing with you the 3 phases of end of life, how to care for somebody at the end of life, the 9 essential questions that you need to answer in order to have a positive end of life, not just for you, but for your loved ones. And one of my favorites is how to live a life full to the fullest right now, starting today, so that you get to the end of it and don't have any regrets. This is a live masterclass. It is completely free with the order of your book. So grab the Good Death book with the link below, and we'll see you in class.